It's my pleasure to introduce Dr. Mookherjee to present a medicine grand rounds this morning. Dr. Mookherjee is an associate professor of medicine in the Division of General Internal Medicine and serves as director of both the Hospital Medicine Faculty Development Program and the newly created UW Academic Hospital Medicine Fellowship Program. Dr. Mookherjee obtained his medical degree and completed his house staff training here at the University of Washington, which was followed by a hospital medicine fellowship and completion of the Teaching Scholars Program at the University of California, San Francisco. Dr. Mookherjee's clinical practice is based at the University of Washington Medical Center, where he specializes in hospital-based medicine and perioperative care. His research interests include evidence-based physical examination and optimizing teaching of medical students, residents, and faculty. He has published extensively on peer feedback of teaching, physical exam education, and education in quality improvement and patient safety. He is the co-editor of the Handbook of Clinical Teaching and the Perioperative Medicine Consult Handbook. Please join me in welcoming Dr. Mookherjee as he presents Improving Clinical Teaching. Can you give me some feedback?
Thank you very much, Dr. Murphy. That was awesome. That was amazing. If you've never been introduced, I highly recommend it. That felt really good. If my mom was here, she would be in tears. She would be weeping in happiness. So thank you. That was great. So you heard a lot of my origin story already, but I'm a UW lifer. I don't know if that's the right term, not in the prison sense. I'm here voluntarily. I've been here I was an undergrad for 5 years, and then a medical student for 5 years, and then I did my internal medicine residency here for 3 years. And like many of you here today, I went from being primarily a learner as a resident one day, and then the next day, I was the attending, and I was in charge of educating my students and residents in internal medicine. So this was a huge change, and I did my best to be a really good teacher. And I remember that first year, I tried to make rounds really fun and exciting and unpredictable, kind of like a game show. I think that worked really well. So let me give you an example. It's Dr. Jackson was on my team and we were rounding. I'd say, for example, I'd just ask little questions like, so what's the half-life of rivaroxaban? Wrong. So, you know, that was, she flinched, and with the flinching comes learning. That was my strategy the first year. And if you leave early, I'm just setting the stage. That's not the take home, all right? Don't remember that. And I remember crafting these really intricate PowerPoint presentations with every possible animation. Stuff would be spinning in from the side and the blinds. That was my favorite, when stuff kind of comes in like blinds. And then you'll be surprised to hear at the end of the year, when I got my evaluations, they actually were not very good. They were not very good. And I seem to remember a couple comments from that year. One was great attending rounds. So that was good. And then the other one was fantastic attending rounds, semicolon, parentheses. So fantastic attending rounds, wink. So I'm not really sure I wasn't sure what to make of that. And so then the next year I went to UCSF and did a 1-year academic hospitalist fellowship. And I did the same thing. I tried my best to be a really good teacher. And at the end of that year, once again, my evaluations were not that great. So I sat down with my division head, Bob Wachter at UCSF, and he suggested to me that, well, maybe it was time to take a more deliberate, purposeful approach to improving my teaching by using feedback to improve my teaching. So many of you in this room, I know, actually, I think I know basically everyone here, and I know many of you are great teachers. And maybe you started out as great, maybe you had a lot of attention to your teaching early, but there's a lot of great teachers here. And then by definition, some of us are average teachers, and you know, your evaluations may go up and down, but if there's a great, there has to be an average. That's just the way it is. And then there's me. So I think it's possible that if I went year by year by year, maybe the natural history of an attending is that my teaching would eventually improve. But I took a different tack with that feedback from my division head at UCSF, and I decided to embark on a series of more frequent, targeted, purposeful feedback on my teaching by my peers. And as a result, my evaluations have actually improved. And I'm very proud to say that my evaluations are now above average. So that's, yeah, hold your applause. Thank you. That was, and so, you know, if someone asks you how was the ground round speaker, and you say, well, I thought he was average, but he thought he was above average. But so every year, actually, when I have my annual meeting with my section head, I ask Dr. Amory, are my evaluations still above average? Because, you know, I give these talks about teaching, and it would be nice to be able to say that I'm above average. So this year, he spent a couple minutes looking through the numbers, and then finally he was like, yeah, you're still above average, and then he went like this. So I think he meant to do this, but I think, so the answer to this question mark here is, for me, it's been leveled off. So I've got to still work, I've got to still keep working on this. And I intend to, and that's kind of the point of this ground rounds today, is I'm going to draw on my experience as someone who's continuing to try to improve my teaching and share those lessons with you today. So there are 3 objectives for this talk. At the end of the next 3 hours, you'll be able to deconstruct excellent teaching into themes and teaching behaviors. And by the word behavior here, I don't mean to give it the connotation that we might use with our kids, like reprimanding them for behavior or good behavior or bad behavior. This really represents the sum total of the words and actions that we use to teach. So that's what I mean by teaching behaviors. The second objective is that I hope that you'll be inspired to employ teaching behaviors that support a positive learning climate. So I think of all the ways that you can break down clinical teaching into themes and behaviors, one that emerges as consistently very important is the positive learning climate. So as we go, I'll be sharing some lists of themes and behaviors, but the ones I want to highlight and the ones to attend to the most are those that have to do with the positive learning climate. And the last objective here is kind of aspirational. I hope that after this talk, you will be inspired to seek out peer feedback on your teaching to try to improve your teaching. So the roadmap for the next 1 hour, right? All right, thanks, Dr. Murphy. It is outlined here. I'm going to spend a little bit of time talking about our histories, the history of how we conceived of clinical teaching, the history of medical education, and I think this is really important because this is, talking about the history, is systems-based practice. This is the awareness of and responsiveness to the larger context and system of healthcare. So in this case, our history is our system of healthcare that I'm referring to. And I think it's enriching to us in our practice as physicians and students and residents to understand where we came from, to understand the present challenges in the context of the past. So I'll spend a few minutes on that. In the next part of the talk, I'll summarize the origins of describing clinical teaching as themes and behaviors. So I think it's important to understand where these constructs came from so that we share a mental model of describing clinical teaching. You can't hope to try to improve something unless you use the same vocabulary and you use the same words to describe a phenomenon. And then I'll end by briefly presenting 3 faculty development experiments that we've done over the years on peer feedback and teaching. So I just wanted to remember to remind, should have practiced this one, sorry. Remember to remind everybody that the ultimate goal is happy patients. So I hope you all in this room believe that better teaching leads to better learning, leads to better doctors, leads to better outcomes and better health outcomes. So that's kind of the underlying premise. I'm not going to prove that today, but I hope that we can all buy into that as we move forward. So the first medical schools in the colonies were the medical department of the College of Philadelphia and the medical department of King's College in New York. Back then, medical education was a 2-year program for a Bachelor of Medicine. The first year was preclinical and the second year was the clinical training. And for a Doctor of Medicine, you would have to do an additional 3 years of training, including a thesis in Latin. So things have changed. These 2 medical schools graduated about 50 physicians, and then by the time of the Revolutionary War, they were both gone by then. After the war, there was a new increase in number of medical schools. And the first three are listed here: Harvard, Dartmouth, and my personal favorite, Transylvania University. It's like, where are you going to medical school? Transylvania Medical. But actually, this was 100 years before Dracula, so this wouldn't, it seems spooky now, but it wouldn't have been spooky back then. And I've shown you some of the tickets that, as a medical student, sorry I forgot, I'm supposed to use the mouse, that you had to buy if you were a medical student. And I like this one. I'm just going to use the pointer. I like this one because this shows three skeletons dissecting each other for an anatomy course. So you'd have to buy this ticket to go to the anatomy course. And this one here is for the infirmary for the relief of the ruptured pore. So this was a clinical ticket that you would have to buy for your clinical training at a free clinic for hernia repairs. So this is how your salary would be paid, would be by selling tickets to your lectures. The 1800s brought rapid change to the United States and to the medical system. The population of the United States went from about 7 million in the early 1800s to about 40 million by the end of the 1800s. The number of general public hospitals went from about 3 to 150, and the number of medical schools went from about 7 to about 150 as well. And the majority of these schools were called proprietary medical schools. So they were not affiliated with a teaching hospital or with a university. It was basically any group of doctors could get together, decide they were a medical school, sell tickets, and then at the end, certify the physician. So this editorial cartoon is from that time. It depicts the Philadelphia physician factory, and you can see it's kind of churning out these doctors who are then running up people with saws and knives to amputate their limbs. So this was a period of turmoil in medical education. And as I looked through the literature and I was trying to find, well, what is the first example of attention to the actual act of clinical teaching? I came across this editorial in JAMA in 1892. So I'm going to actually read this aloud because I thought this was really surprising that in 1892 someone would say this. The time has come when the art of medical teaching must be taught. It is folly to suppose that because a man is a physician, he is, by that token, a competent medical teacher too. But whoever may choose to become a teacher of medicine, let him first learn how to teach. Let him study some method of conveying instruction. The idea seems to have been grasped by the Pan American Medical Congress. This is notice to platitudinous addlepates that the old-fashioned dissertation on higher medical education may be left on the dust-covered shelf. So I was really excited when I saw this, and I actually looked up the program for the Pan American Medical Congress, and I thought I'd find the first workshops on clinical teaching with role-playing and, I don't know, maybe powdered wigs and getting dressed up and stuff. But I was disappointed to find that all the talks about teaching really were what this person said should be left on the dust-covered shelf. They all had to do with structures and processes and curriculum. And so it actually was all platitudinous allopates. So the next reaction to this kind of disarray in medical education, poor quality physicians, was the Flexner Report. So in 1908, the Carnegie Foundation commissioned Abraham Flexner to survey all the medical schools in the United States. And so he went to all 155 medical schools and surveyed them on the items that are listed here. I won't read them aloud to you. And he made several suggestions on the basis of his findings. Number one, he advocated for stricter entrance standards. He said that all medical schools should be affiliated with research institutions. And he basically set the model for what medical education is today. It was the Johns Hopkins model, and I think very much the University of Washington model. So on the next slide, I'm going to share something else Flexner said. And my purpose in sharing this is not to shock you, and it's certainly not for entertainment purposes, but it's systems-based practice. This is the larger context of our of medical education. Forgive me for the harshness of the terms, but I think it's important for us to get both sides of the picture. So Abraham Flexner also said, if the Negro can be brought to feel a sharp responsibility for the physical integrity of his people, the outlook for their mental and moral improvement will be distinctly brightened. The practice of the Negro doctor will be limited to his own race. So this was hugely consequential. At the time, there had been about 7 traditionally black medical schools, and after the Flexner Report, this was reduced to 2, Howard University and Mookherjee Medical College. For the first time after the Flexner Report, the percentage of African-American physicians decreased in the United States. And this is in the context of the life expectancy of African-Americans at the time was 34 years compared to 50 years for white Americans. So this is the other side of the coin, and I think it's really important for us to appreciate the roots of what we see today. So far, this very brief survey has talked about physical structures and personnel, content organization, leading to better learning. And so it was only in the 1950s that we started to see increased attention to the actual act of clinical teaching and improving clinical teaching. And this graph depicts how exponentially the number of publications in medical education rose starting in the 1950s and 1960s. Similarly, the vocabulary that we use today on a regular basis, words like professionalism, reflection, self-instruction, evidence-based medical education, was basically non-existent in the 1950s. And since then, the numbers have, as you can see, just blossomed. And the University of Washington was actually in the middle of this process in the 1950s and 60s. In 1945, the state legislature appropriated funds for the University of Washington School of Medicine. And in 1946, the first faculty was assembled. Here you can see Dr. Edward Turner, right, the first dean of the School of Medicine. And the building that we're in right now, the groundbreaking in 1947, and the first graduating class in 1950. And if you're interested in this history, I'd recommend 2 books, Saddlebags to Scanners, which was written by Nancy Rockefeller, and a chapter on the University of Washington School of Medicine by Clement Finch in our department, from our department. And Clement Finch also wrote Fulfilling the Dream, which is a dedicated history to the University of Washington School of Medicine. So I've returned both of these to the library, so you can check them out. Okay, so now we get to, well, what is good clinical teaching? This is the second part of the talk where I want to outline how we start thinking about behaviors and themes in clinical teaching. So the early literature approached this from 2 different aspects, learner perceptions and faculty perceptions. So I'm going to share with you 4 early papers that took this on. The first paper is from Dr. George Miller in 1956. Dr. Miller was an important founder of faculty development in academic medicine. He started the University of Buffalo project in medical education, which has since been the prototype for lots of departments and divisions of medical education around the country. And in this paper, he says, perhaps the time has come to face up to the fact that many of us do not know what we are doing as teachers, that those who do learned it accidentally and cannot readily communicate it to others. So he gathered 12 faculty and they talked for 20 hours, and this got published in JAMA, so you can tell that at the time there really wasn't much in this realm being published. And so here are the themes that they came up with, and I'm not going to read all of them aloud, but I want to highlight the ones that have to do with the learning environment, the learning climate. Teaching or learning is largely an emotional experience, and students must be helped in wanting to learn rather than just to know. In 1962, Hilliard Jason was a medical student, actually, at the University of Buffalo, and he was very interested in improving clinical teaching as well. So he created the first structured clinical teaching evaluation form called the Medical Instruction Observation Record, and he created items based on reviewing the literature and suggestions from experienced teachers. This was, in the literature, one of the first times we hear someone advocating for using behavioral terms in describing teaching. So the emphasis was less on the knowledge of the teacher, but more on what they're doing and what they're saying. And he organized his items into 7 themes based on similarity of the items. And I've, again, listed the themes, and I'm not going to read them all aloud, but I want to highlight attitude to difference. So it's negative, it's bad to insult students. I didn't know that. So it's good to write these things down. A positive behavior is reacting to criticism with understanding. Sensitivity to physical setting, attitude to students, reaction to student needs, and you can see the rest of them listed here. In 1975, in this study, Stritter and his colleagues asked students to rate the favorableness of 77 different teaching behaviors or teaching approaches. And the top 5 behaviors are listed here. And again, I want to highlight the ones that have to do with the learning climate. So approaches teaching with enthusiasm. So that comes up over and over and over and over again. If you look at the literature on clinical teaching, enthusiasm, learning climate is a very important theme. So next, Stritter did factor analysis on the 77 rated items. So factor analysis is a statistical technique in which you're trying to describe a larger phenomenon like clinical teaching, and you try to characterize it with a lot of different items, like 77 items describing clinical teaching. And then you extract underlying factors that explain all of these items. And so it's based on correlations between each of these variables. So the 6 themes that came out with factor analysis are listed here, and I'll highlight preceptor attitude towards teaching, student-centered instructional strategies, and humanistic orientation. So this is an excerpt from Stritter's paper, and does anyone notice, take a look, and anyone notice anything interesting here? Dr. Ford? Okay. All right, thank you. He. So I'm not picking on Stritter. This was clearly the convention at the time, but it was a biased convention, and I don't want to gloss that over in talking about this, about clinical teaching. So you may ask, well, why in a talk about clinical teaching are we talking about bias when we just had this fantastic grand rounds from Dr. Sarawich earlier this month on bias? Well, that's why, because we got to keep talking about it. And I get to do grand rounds, so I'm going to keep talking about it. I think it's important that we keep talking about bias. And then secondly, bias is hugely important and influential in the clinical teaching environment. So I think we need to acknowledge it and meet it head on. So this graph shows the increase in percentage of women in medical school over the years. And you can see it steadily increased. I only got the data up to 2015. I think we're up to like 50%, right, nationally, even now. But despite this, so this is, I think, a couple generations. Despite this, we're still lagging behind in the highest levels of leadership in academic medical education. So this is all chairs of clinical and non-clinical departments in all schools of medicine in the United States. So 18%, only 18% are women. The last time 18% of women were medical students was in 1975. Same thing with deans of School of Medicine. Minorities in medicine. So I realize that in some ways, kind of creating a binary between white and minority is kind of nonsensical. My kids are half white, half Indian. Are they minorities or are they not? I don't know. Different minorities have different experiences. White people have different experiences. So I don't mean to oversimplify, but I think it's still a useful construct to use to think about bias. And we see the same sort of patterns with minorities in medicine as well. So only 22% of nationally chairs in clinical and non-clinical departments throughout the United States are minorities. And I couldn't find this actual statistic, but only a handful of deans of School of Medicine nationally are non-white as well. So this is important to understand because this influences the learning climate, and our learners actually feel this as well. So this is the 2017 AAMC graduation questionnaire, and you can see that 28%, the denominator here is all graduating medical students, and I double, triple check that we're talking about all graduating medical students. 28% at the UW have been subjected to offensive sexist remarks. 27% feel like they've been publicly humiliated. 11% think that their grades are lower because of their gender, and 6% feel that their evaluations are lower because of their race or their ethnicity. So this is hugely important, and this has to do with the learning climate, and my purpose here was to raise awareness of bias in the learning climate. So this was a non-digression, and I'm going to return to one more study, because everyone's in a bad mood now. I'm going to finish with one more study that was done at the UW on clinical teaching, and this was by Dave Irby, who was at the UW from 1972 to 1997, and is now, I think he's retiring this year at UCSF. And what he did was he grouped 61 teaching behaviors based on his literature review into 7 themes, and then he asked 268 UW students to imagine their best clinical teacher and their worst clinical teacher and rate them on these items. And then he did confirmatory factor analysis on these items to see if they would fit into his themes. And so they mainly fit. The 7th theme here, modeling, was actually subsumed around group instructional skills. But otherwise, there's good evidence that organization, clarity, group instructional skills, enthusiasm, knowledge, clinical supervision, and clinical competence are important themes in clinical teaching. So there have been lots of other studies in this realm, at least 20 other studies characterizing clinical teaching based on observations, surveys, theory, focus groups, and dozens of instruments have been constructed. So I'm going to tell you a little bit more about one instrument that I was trained in, the Stanford Faculty Development Program Clinical Teaching Instrument. And this is what I leaned on when I was trying to improve my teaching at UCSF. We had someone who had been trained in this framework. He gave me feedback using that terminology, and I tried to improve my teaching using that same framework. So it's a 25-item tool that was based on literature review. It's a month-long training. You have to go to Stanford. I think at our institution, only Scott Smith in Boise has done this. Does anyone know of anyone else who's done this? I don't think anyone else has. And it's a dissemination model. After you get this training, you go back to your home institution and you teach others. And that's how I learned about it. I did a 7-week, 2-hour per week training in this model. And you can see here that folks go throughout the world after they get their training. And this is Kelly Skeff and Georgette Stratos who came up with this whole model. So this is the framework. There's 7 themes: learning climate at the very top, control of session, communication of goals, promotion of understanding and retention, evaluation and feedback, and promotion of self-directed learning. I'm not going to talk more about these today, but there's lots of resources available where you can learn more about this framework and how you might be able to use it to improve your teaching. There is a lot of evidence to commend this framework, a lot of validity evidence, both in terms of content evidence. The response process is less so. I couldn't really find any support for the response process. Internal structure, so do the items fit the construct? And so this is factor analysis, and there have been multiple factor analyses of this framework that support thinking about clinical teaching in this way. Relationship to other variables, so in other words, if you do well using this framework, are your evaluations using other means also high? Does it make sense? And then consequences, does it have the desired effect? So there's been many studies, actually, I would say at this point, dozens of studies of this framework throughout the world that show that using it improves teaching. So it's a good framework, and they haven't paid me to advertise it, and I realize that I trained in it, and that's why I like it. But I actually think even after looking thoroughly through the literature, this is one of the strongest frameworks to explain clinical teaching. So how do you use it? How do you operationalize a framework once you have it for clinical teaching? Well, the answer is feedback. You use feedback. And so I'm going to explain that using Kolb's experiential learning cycle. So in this model, you have a concrete experience, then you reflect on it, then you learn from the experience. That's the conceptualization part. Then you try something out based on what you learned, then you have another concrete experience, and that's a cycle. You keep doing that until you improve. I think the problem here is that when you reflect and you learn, you don't know what you don't know. This is obviously an exaggerated example, but I did do something similar to this, saying wrong to Dr. Jackson. At the time, I thought it was reasonable. I don't mean this example, but when I did it as a first-year attending. And so I needed someone to observe me and tell me that, did you notice her face when you did that? But you thought it was a fun game showy kind of thing, but she looked sad. So that's where peer observation and feedback comes in, is helping the teacher to reflect and to learn from the experience. So peer feedback in particular has a lot to commend it. You don't have to be an expert to be a good peer observer. A lot of folks hesitate to observe and give feedback because they worry that they're not an expert teacher. Well, if you have a shared mental model and you can talk about behaviors, anyone can be an observer and give feedback. The observer benefits. This comes up over and over again whenever we do an experiment on peer observation and feedback, and then we survey everyone. The observers always say that they liked it a lot. They benefited from the experience. It creates a space to discuss teaching that might not otherwise be there. And it has the potential for creating supportive partnerships as well. It can be a prod to promote more mindful teaching. If you know that someone's observing you, maybe you'll think more about your teaching behaviors. And then finally, there is growing body of evidence that peer observation and feedback helps improve teaching. So in the final part of this talk, oh yeah, we're doing fine. That's control of session on the framework. All right. In the final part of this talk, I'm going to talk about 3 faculty development experiments that we've done over the years. So the first is one in which we assigned dyads to observe and give each other feedback. The second was peer observation based on convenience matching. And then finally, a clinical teaching champion model, which is currently underway in our division as well. So the first model is using assigned dyads, and this was done at UCSF as part of the UCSF faculty development program. In this experiment, we trained hospitalist faculty, there were about 20, in a 2-hour training session on peer observation and feedback using the Stanford model. We used videos to practice observing, practice identifying behaviors, and how to give feedback. And the way that we trained folks to give feedback is the same, and it's applicable to the next 2 experiments as well, to start by eliciting self-assessment. So that's the reflection piece, giving behavioral feedback, not saying that I thought you did a great job. Like, I guess that's okay to say, but what does that really mean? Well, I thought you did a great job in explaining what the objectives were for the talk, as an example of a behavioral piece of feedback. And then finally, together collaborating on and discussing plans to improve. So we measured some outcomes pre and post this intervention. These are small numbers, but I think still significant. We asked about accuracy in assessing colleagues' teaching skills, confidence in giving accurate feedback, giving feedback in a way that colleagues won't feel defensive, and then was there improvement and confidence and ability to teach. And so all of these improved, and I realized the swooshing arrows kind of emphasize the differences, and the numbers maybe aren't that different, but these are all at least statistically significant. And if you look at the medical education literature, these effect sizes are actually reasonable. These are, for an intervention on teaching, these are pretty good movements of the needle for improvement. So all of these improved as a consequence of the intervention. Paying attention specifically to the learning climate behaviors, they both improved as well. Listening to learners, that improved pre and post, and encouraging learners to participate actively in discussion also improved. The next experiment we did with my partner Dan Cabrera at Harborview, and there were others involved as well, but Dan was the main person who was my partner in this project. We did a peer feedback on bedside teaching experiment at UW and Harborview, again, of hospitalists. So in this case, we used the Stanford model and converted it to more of a operational bedside model, adhering to the principles that you can find in the Stanford model, but breaking it down more logistically and mechanistically into setting the stage, role modeling patient-centered care, practicing learner-centered teaching, wrapping up and giving feedback. So we did a 1-hour training, and then folks were asked to observe each other doing bedside rounds, and they were matched basically based on who was available to do the observations. And I'm not going to read all of these items aloud to you, but I want to highlight that all of the learning climate behaviors improved. These are all the learning climate behaviors. And in particular, respecting learner autonomy and acknowledging limitations improved the most. So again, it's a small nudge towards improving the learning climate by using peer observation and feedback. The third experiment is still underway. This is the Clinical Teaching Champions program that is part of the DGIM Faculty Development Program. So we have 6 clinical teaching champions that are shown here, 1 for inpatient and 1 for outpatient at the 3 main teaching sites. And I spent an hour with them. These are all, excellent clinician educators, teachers, observers, but we spent an hour talking about how you might observe using the Stanford Faculty Development Program and give feedback to your peers. And then they were just available and sometimes reached out to their peers to give feedback on all sorts of teaching. And in fact, I think they're all watching me right now and they're going to give me feedback later. And to date, there have been 44 observations and feedback sessions in our division. So that's actually a sizable chunk of our division has participated in this program. And faculty, we surveyed the faculty that were observed, and they were comfortable being observed and receiving feedback. They felt that the observations from their champions were accurate. They felt that participating was worthwhile, but they were less sure that their teaching had improved as a result of this. So a lot of work to do, a lot of troubleshooting to do. I think we can make this program even more effective than it is. But I want to highlight a couple quotes because you don't always get the true assessment from these numbers. Sometimes some subjective quotes are helpful to give you a better sense. So a couple folks said, "This was invaluable. I wish it were an expected thing that we all observe and get feedback from our teaching champions. It is always a gift to have dedicated space to have another colleague reflect on their observations of your teaching." So overall, this has been a very successful peer observation program. So the top 4 lessons from these experiments, faculty appreciate it. So I've given them lots of opportunities anonymously to say, maybe you should drop this. This isn't such a great idea. No one has ever said that. So I think in general, faculty appreciate the attention to their teaching, and they appreciate peer observation and feedback. Structured feedback effectively shines a light on areas for improvement. And there's at least some evidence to support that peer observation and feedback can improve the learning climate. But I think the last lesson here is that it's actually pretty resource intensive. It takes a lot of attention to this to sustain it. It's not like a seed that you plant and then it's going to turn into a tree and people will keep doing it forever and ever. It needs constant watering and attention to continue peer observation and feedback. So in summary, my take-home points are traditionally structure and content, personnel, curriculum have been emphasized when you think about optimizing medical education over clinical teaching skills. And then it was only in the 1950s that we started seeing attention to clinical teaching. Breaking down clinical teaching into themes and behaviors is a good method to identify areas to improve, have a shared mental model of the same vocabulary to get feedback and improve your teaching. The learning climate is key, and this comes up over and over again in the literature. If there's one thing that you can do to improve learning, it's to pay attention to the learning climate. And then finally, to learn and improve, remember to ask, can you give me some feedback? So, and your feedback would be very welcome to me today as well. Thank you very much. I've listed some of my mentors from UCSF and the University of Washington. Thank you.